As has been said in the introduction, I'm a clinician. I'm a physiotherapist by training, but have worked in sleep now for coming on to 30 years, and mainly in the area of sleep-disordered breathing, sleep apnea, but that does interact with getting a good night's sleep, and we give much advice to poor sleepers and people with insomnia. I'm also an academic at the University of Canberra, so a lot of the principles that we try and apply with patients are evidence-based. They're based on research that has shown efficacy and improved outcomes for patients. Yeah. So I will mention a little bit about sleep apnea and treatment. So one thing to remember is that there are certain products that are used for treating sleep apnea, CPAP machines, and so we do rent and sell them at the clinic. So do sort of take on board that disclosure as we start the presentation. So the sort of information we're giving today it's generic in nature. It's sort of a good starting point for your own research and your own discussion with your healthcare professionals as to what might be suitable for you. Everyone's situation is individual, and so do discuss the recommendations and things you might want to do with your healthcare professionals. I'm a physiotherapist by profession, so we don't deal in pharmacological agents and that side of things. So I won't be addressing that in the presentation or in the question time. I can respond to your questions, but do keep them of a sort of general nature rather than specific to your individual situation. And I won't be able to answer questions about drugs and pharmacological agents. So what do we want to cover in this sort of half an hour, 40 minutes that I'm going to be chatting for? So we want to look at normal sleep and the sort of conditions that occur in Parkinson's disease, survey some of the common sleep issues, and then give you some practical things you might do to improve your sleep. And under that also I'll talk about this condition of sleep apnea, which is very common in the general community and more common as we age as well. So what is sleep? Well, sleep is this time where you become disengaged from the environment. And when we're measuring sleep in the sleep lab, we use certain physiological signals to score and define sleep. So we use three specific signals, that being the brain activity, the EEG, electroencephalogram, the electrooculagram, so the eyes, what's happening with the eyes. The eyes are like a battery within the skull, and so when the eyes move, we can pick that up electrically, and that will allow us to determine certain sleep phases, particularly rapid eye movement sleep. And then we look at EMG, muscular activity. So when we're determining the sleep phase, we'll usually put electrodes on the chin to determine the global muscle activity. But in certain conditions, when there's movements at night time, we might be measuring other limbs as well, such as the arms, or more commonly, the legs in a condition such as periodic leg movements during sleep. But we use the muscular activity to help us determine the sleep stage. Now, sleep is broken up into non-REM sleep, where the brain slows down, and REM sleep, where the brain is more active, but the person is completely paralyzed at that stage generally, so we don't get up and act out what we're dreaming about. Now, there's these flow of sleep across the night. This just shows you what happens in the REM phase in terms of these example physiological variables that I've been talking about. So these are the brain waves, the movements of the eyes, the right and left eye, moving phasically, like the person's looking around at what's going on. And very importantly, the chin EMG, the muscular activity in the chin, is completely silent. The person it's almost like they're a quadriplegic and there's no muscular activity within the body. The only muscle that's working is the muscles in the eyes and the diaphragm, which is sustaining breathing. And this means that we don't get up and act out what we're dreaming about. Now, a condition that is quite common and can be a precursor within Parkinson's disease is REM behavior disorder, where the person actually starts to move during their sleep, sometimes quite aggressively, and it's thought to be the dream content, acting out the dream content. Now, this just shows you the way these phases of sleep are distributed across the night. There's rhythms of sleep. There's the circadian rhythm, which is driving us into the sleep, but there's also these other rhythms, these ultradian rhythms, and these are the rhythms of the phases of sleep across the night. So here the different stages are given different colors, and you can see the periods of REM sleep in this individual, 4 periods of the REM sleep across the night, and then going into the deeper stages. So stage 3 is the lighter and darker blue. That's the really deep sleep where the brain modes are very slow. You can see that most of the stage 3 sleep is in the first part of the night, and that's thought to engender survival advantage to us as a species, because we get, if you're going to have a power sleep that's going to go just for a few hours, you'll get all the stages and you'll particularly get this deeper sleep. So this is called a hypnogram. It's a way of drawing out the person's sleep stages, and we can quickly see if that person's sleep is abnormal in terms of its depth or in terms of lots of wake-ups across the night. So when we do a sleep study, we can do it in a number of ways. We can do it at home, and very commonly now sleep studies are done in the home or versus in the lab. And it does depend on why you might be doing the study, what the sort of clinical presentation and the issues are for the client as to what type of study you might do. But what I can say is that people find the home studies, not too difficult. They don't find it enjoyable for sure, but they find it quite doable to take a kit home and to sleep in their own home with the gear. Obviously, there's a number of electrodes we're putting on the patient, so it's not a particularly normal night's sleep, but we do see all the physiology going on. So here you can see the sorts of things that we might measure in a home sleep study: brain activity, eye movements. Often we don't measure the muscular activity of the chin in a home sleep study, which is different from one that you might do in lab. We measure heart variables, the position of the person, and a number of breathing variables. Also, we frequently measure the movements of the leg, but often in a very limited way. So this varies from a lab study where we might be able to put a lot more electrodes on the person because we have staff there to supervise them, and we can measure more muscles and different variables. The other important thing about the lab is we can have video going, and we can video the person and see what they're doing in terms of movements, acting out behaviours and that sort of thing. So it all depends why we're doing it, whether there's a suspicion of disordered breathing as the primary issue, or whether we think there might be some sort of movement issue going on. So it varies which is the best. Sometimes the person will do a home study, and if that doesn't give us a clear result, then we'll move on to the lab study. But one thing I would say is not to be concerned about these investigations. They're done very, very readily. They're a very common investigation these days. So in terms of Parkinson's disease, what are the sorts of issues that might happen with sleep? And it is a very fertile area of research and a lot of research which has different results, and there's really no definitive conclusions as yet for a lot of these questions. But these are some of the common issues that people complain about and are concerned about and are presenting to their doctors with. And the first two are the ones that I'll mainly talk about today. They are insomnia and poor sleep and sleep apnea. People with Parkinson's disease can be tired during the day, and it has been argued whether there is an intrinsic hypersomnia, a sense of sleepiness in the disease itself, and that is still argued, but there's increasing evidence to suggest that the sleepiness can be a side effect of medication. Movements of the limbs, such as periodic leg movements where the legs are jerking periodically overnight, or restless legs syndrome where the person feels that they want to move the legs. They get a strange feeling within the limbs, and this need that movement is required. REM behaviour disorder, these movements in sleep, which I've sort of discussed and mentioned already. And then there can be circadian rhythm disorders. So the person has a tendency to go to bed too early, and so they're waking up very early in the morning, or they have a delayed phase of sleep where they're going to bed very, very late, and this makes it very hard for them to get up in the morning because they might be going to bed at 2, and so their usual waking is around 10 or 11 in the morning. But I'll mainly talk about these first two. So in understanding poor sleep, we just need to understand the underlying sort of normal physiology of sleep. And this two-process model helps us here, where we have these two processes that are driving sleep. And then on top of that, we get the cognitive factors, all the thinking factors, or the activity of the brain. And you'll all know yourself that sometimes you'll be awake in the middle of the night and your brain is racing and you can't sleep, even though there are other factors which are driving you to want to be asleep. And that's the fact that you've been awake for a long, long time. So these are the two factors: process S, which is the brain's intrinsic drive to go to sleep. So the longer you're awake, the more of this process S you get, this drive for sleep. So here we can see a model in which this drive to sleep builds up across the day and then is released across the night when the person has a normal sleep. The other factor is circadian rhythm, the changes in the hormones, melatonin being the hormone that is triggering sleep. And so these two processes work together in this sort of healthy individual so that they're sleeping here from 11 o'clock at night through to 7 in the morning. Then the next day they wake refreshed, their sleep drive builds up across the day, and then they fall asleep at 11 the following night. So one of the principles we use for improving people's sleep is to try and build this sleep pressure by keeping them awake so they're more likely to fall asleep, and getting this pressure in the rhythm of the normal circadian cycle, the secretion of the hormones. So one really important thing to say about not sleeping well is you sort of may attribute it to your condition or to a health issue, but age is very, very important. And obviously we're all getting older, and this has an impact on sleep. And one of the things it impacts is the secretion of the melatonin, the natural sleep hormone. And here you can see as we get older, there's less of the hormone. So it naturally becomes harder to sleep as we get older. So, and sometimes we might have unrealistic expectations about our sleep. And often it's important to think more truthfully about it. So, you certainly can't, I can't run as fast as I did when I was 18, and unfortunately I can't sleep as well because of the difference in the secretion of the hormones you can see with age. So when we understand poor sleep and what might be causing someone to sleep poorly, we think of a number of factors, and various models have described these things. And so it's good to sort of understand these factors and what we can reverse in our own situation, which may then help us sleep better. So this model here is one where this dotted line is, it's like a bar graph, and the dotted line is where the person says, I'm sleeping poorly. It's the threshold for this report of poor sleep. And in someone who is a poor sleeper, there's usually three factors which are leading to the situation. One is a familial preponderance to poor sleep. And this is in every single human being, that because of the nature of sleep, that it can be disrupted. But there are things like, concern about our well-being. Well, everyone has a concern for their own well-being, but some are more concerned than others. So there are certain underlying factors which can lead to poor sleep, and they do vary across the community and across individuals. There's usually some factor that starts to get someone sleeping poorly. That may be something like pain. It might be stress related to a disease or job loss, or grief related to the loss of a loved one, for example. Various things can precipitate starting to sleep poorly. But then over time, those factors tend to wane. And then these other important factors in sleeping poorly start to dominate. And these include an excessive focus on sleep, increasing time in bed while awake, and daytime naps. So this is just three examples of some of the things that might impact on someone and perpetuate this continuance of a poor sleep pattern. So here we can see like a model of these things developing as a person moves to poor sleep. So they have this sort of pre-morbid propensity to poor sleep, precipitating factor which pushes them over the threshold, but then these perpetuating factors such as worry about sleep, being in bed for too long, napping during the day, start to take hold, and then that becomes the dominating feature of their presentation. So there's a lot of research that underlies this poor sleep. And this slide here is gathered from a review article which looked into all these factors which are generally common of people presenting to their doctor with poor sleep, or presenting to insomnia clinics with prolonged chronic inability to sleep well. So as we look down the list, you might think to yourself, are these some of these things relevant to me, and are these some of the areas I should be looking at to change? Obviously, it's quite cursory what we're doing in this presentation. I can't go into the specifics about each. You could talk for 15, 20 minutes on each of these. So we are covering a lot of ground in today's presentation. But hopefully this is giving you an idea of the sort of principles and how we are linking the behaviour to the underlying science and physiology of what we know to be a normal night's sleep. So I've already mentioned this one already. People who sleep poorly tend to spend too long in bed, and they're spending too long in bed being in a awake state. They start to build up this relationship with the bed, which is not related to sleep, but it's related to being awake. Irregular timing of retiring and arising. So they might be going to bed at different times and arising at different times in the morning, sleeping in, for example. Yeah. Unpredictability of sleep. So you're not sure what part of the night you're actually going to be able to sleep in. Worrying about daytime deficit. So worrying about how am I going to function tomorrow because I'm not sleeping well tonight. Yeah. And so these concerns, they can be real at times, but most of the time when we do study people who are sleeping poorly, it is remarkable how they do function at really quite a good level despite not sleeping well. Multiple bouts of naps and fragmented sleep. Yeah. So generally speaking, we prefer people not to take sleeps during the day or have naps, although sometimes that really is necessary for a person. And particularly with people with health conditions, they do really need to have sleep during the day just to be able to function in the latter hours and into the evenings. So generally, our principles here are to keep naps short. 20 minutes would be absolutely optimal, and have that early in the afternoon. Before 3 o'clock would be the ultimate time to have a nap to try and avoid affecting the next night's sleep. But obviously, these are principles and one needs to work them into your own schedule. Maladaptive conditioning. So this just describes where people associate various factors with sleeping well. You know, when I use a certain type of doona or when I have the curtains in a certain way, I seem to sleep well. Well, it isn't these factors, but the person has associated these things in their mind. People who sleep poorly tend to have increased caffeine consumption to try and maintain wakefulness, and this can affect sleep at night. So we try to get people to avoid caffeine after 12 midday. Then the use of sleeping tablets and alcohol to try and help sleep. Unfortunately, alcohol, whilst it might help you get off to sleep, it will worsen your sleep in the latter half of the night. It will fragment your sleep. So overall, your sleep will not be as good after alcohol ingestion. So these are things that are commonly found in studies, behaviours of people that aren't sleeping well, and these are the factors that in treatment we try and reverse. So these are some sort of practical recommendations to you. One thing would be that try not to worry if you're not sleeping. Yeah, obviously sleep can be an issue, and obviously I'm all in favour of high quality sleep. It's what I've spent my whole career trying to promote, but you're not going to sleep better by being worried or concerned about it. Yeah, you're best to just try and lie there quite relaxed, not trying to promote sleep. And if you ask a good sleeper how they sleep so well, often they will look at you very blankly and say, well, I just sleep. Yeah, and that's because it's not associated with any degree of worry. Yeah. Efforts to initiate sleep can often be counterproductive. So, thinking, oh, I think I'm just about to drop off to sleep now, can often be counterproductive. It can actually wake you up. Now, dealing with a racing mind is something that's done professionally by a psychologist, and there's a lot underlying that, but some basic principles: allowing time to unwind in the evening. If you've got concerns, to document those, to write them down, to get them out of your mind before you go to sleep. So put the day to rest. Some people find relaxation and imagery is important, but give up trying to sleep. These are some other recommendations which go along with those principles. One of them here I sort of pick out is you don't need a clock in the bedroom, or if you do have a clock, turn it round so that you can't see it. You can't see the time. If you need to get up in the morning, set your alarm clock to get up at a certain time. And one of the basic principles of getting a good night's sleep is we set a time to wake up in the morning, and we stick to that time if possible. We try and avoid sleeping in if possible. So wake up at the time your alarm goes off, or that set time each day, and then start the day. Open the curtains, get out, get up and get moving, and expose yourself to a lot of light in the first 2 hours. If you can go out and have a walk or have your breakfast in full sun, but get plenty of sun into the eyes in that first 2 hours, that strengthens the natural body's circadian cycle. Yeah. So you're not worried about your sleep. You've got this new attitude to your sleep where you know that the physiology will take hold. It's a natural rhythm. And so you don't need to be looking at your clock at the night. You don't need to look at your clock and say, oh, it's 2 a.m. in the morning. I need to start worrying now about whether I'm going to fall back to sleep. Yeah. If you wake in the night, you just sort of go, well, ho-hum, yeah, I've woken up. I may take a short time, or I may take a long time to fall back to sleep. It's not going to worry me. I've got a new attitude towards sleep. But when the alarm goes off in the morning, I'm going to get up and get about my business. Yeah. Don't use bed as a place to solve problems, and I've sort of talked about that already, trying to put the day to rest. Try to do some exercise during the day, preferably not near the time when you're going to go to sleep, so not within those sort of 4 hours of your bedtime. Don't eat large meals close to a bedtime. Limit your alcohol and caffeine consumption, and keep the bedroom darkened if you can. The bedroom should be like a cave, slightly, just slightly cool, but very, very dark. But obviously some people do need to use night lights and that sort of thing to safely move to the toilet during the night. So we're not against that if that's an issue, but as dark as you can for the room. So here's some resources that I've listed for you, and it could be a good place for you to start your own sort of investigation and research into this area. And there is an overlap between poor sleep and mental health issues very frequently, which can work in both ways in terms of poor sleep tends to increase anxiety and depression, and the other way around. Yeah. So there's a course here. There's a link to a course that's run by This Way Up, which is a University of New South Wales, which you can work through and manage your poor sleep. And there's some other resources there that might be helpful, which you might want to also talk to your GP about. Obviously, in sleep, there are sleep specialists, sleep physicians. They deal with all matters related to sleep, and they are the ones that would generally address these issues around movement disorders that are occurring at night time. So I just wanted to say a little bit about sleep apnea, just briefly, just so introduce that topic. It has been argued in Parkinson's disease whether sleep apnea is more common, both obstructive sleep apnea, where we get a blockage of the airway during sleep, and central sleep apnea, which is coming from the brain, where the messages to breathing stop during sleep. And it still is a point of contention about this, but my reading of the latest evidence is that there really isn't a great deal of evidence that these breathing disorders are more common in people with Parkinson's disease than the general population, although these conditions in themselves have many symptoms which can overlap with issues that might go on in your disease. For example, this daytime sleepiness that can occur. So here's just one of these in-lab sleep study results. And you can see these multiplicity of different tracings we make. But importantly here for breathing, this one through the middle here, this auto flow, is the person's breathing. And this is what happens in sleep apnea. There is a cessation of breathing. Breathing stops because the airway blocks over due to the relaxation of muscles in the back of the throat during sleep. This one below that, the 4S, is actually the person's breathing movements. They're still trying to breathe, but they can't get the air in because the airway is blocked over. And now this causes changes to the pressures within the chest. It causes changes to the heart. And what this eventually does is cause the person to get rid of fluid out of their body, and they get up more to the toilet at night. So one of the symptoms of sleep disorder breathing is increased number of trips to the toilet at night, which can be due to a variety of causes, but many people don't think that they're getting up to the loo at night could be because of a breathing issue. Frequently, the sleep apnea will go along with snoring, so there'll be sounds and the person will snore at night. This is a cross-section through a person's head and neck, and the problem is occurring here in the back of the airway at the level of the palate and back behind the tongue, where the throat actually blocks over, either partially or completely in sleep apnea. And this is where the snoring's coming from. There's vibration here at the back of the throat. So the types of symptoms may vary from no symptoms at all through to a whole multiplicity of symptoms in certain individuals. But the things that people can report are sleepiness and unrefreshment from their sleep, difficulties with concentration, memory, learning issues. Others will describe it not so much as sleepiness, but more a fatigue, tiredness type issue. Occasionally, the person may wake feeling like they're choking, or their bed partner may see them occlude the airway, but that is more rare. And then this getting up to the toilet at night and even wetting the bed at times. When we don't sleep well, as I've suggested, mood problems can ensue. And then more common problems might be this sort of dry mouth or throat, and then a headache at night or in the morning can be associated with sleep apnea as well. The bed partner may have their own sort of set of complaints, and often it's the bed partner that drives a person to our care because the person's snoring, it's disturbing their partner. They may notice these stops in breathing, or there may be this sort of restless sleep pattern, and the person may become quite irritable because they're not sleeping very well. So the associations in terms of risk factors for sleep apnea include age. As we get older, the airway becomes less able to hold itself open, so sleep apnea does get more common as we get older. Generally, sleep apnea is more common in men than females, although after menopause, then females catch up to men in terms of the amount of sleep apnea that's present. As I've mentioned, Parkinson's disease is not a risk factor in and of itself for sleep disordered breathing. We generally think of perhaps, or what is a common myth is that sleep apnea is only going to occur in people that are overweight and obese, and this isn't the case. It is frequently a risk factor in about 80% of clients, but in about 20% it's related to their facial shape. And here we're talking about the size and position of the jaw, which might be important, or other factors which are not so readily seen by examining the person from the outside. We need to look down the back of their throat to see that it's narrow. Yep. So it's not just a condition of people in people that are overweight. Now, there are a number of things we can do for sleep apnea, depending on how severe it is, depending on the symptoms the person has and what they may want to do about it. Yeah. So as I've suggested, if the person's overweight, they may want to lose weight or increase their physical activity. Sometimes the condition's related to the position they're lying in. It's more likely to be worse on their back than on their side. So there's devices that they can wear around their neck which vibrate when they try to lie on their back and keep them on their side. There are mouth appliances, so splints that can be worn top and bottom to bring the jaw forward while the person's sleeping. These are not orthodontic, they're just holding the jaw in a specific position while the person's sleeping. Surgery can be undertaken, although it is a big undertaking to do an operation for sleep apnea. And then CPAP therapy, wearing a mask. You may have seen this type of therapy or know of it. Certainly becoming more common. Every second pharmacy seems to have a CPAP service these days. It's becoming much more common to have CPAP treatment. CPAP treatment reverses this blockage that occurs in the back of the throat by putting air pressure in the back in this area that's collapsing during sleep. And it's an Australian invention. It was invented at the University of Sydney in about 1980 by a fellow by the name of Professor Colin Sullivan, and now used by millions of people worldwide. Yeah. The devices used to be very noisy and cumbersome, but have now been, due to advances in technology, much smaller and lighter, more comfortable to breathe on, and the interfaces are much smaller. This is sort of an example of a very small mask, 45 grams in weight, that is used for applying CPAP therapy to a patient at night. So in conclusion, here are some of the benefits that people can get from CPAP therapy, because obviously it's not a desired treatment. I rarely have a patient come in and say, oh, I'd like to wear a mask at night time when I'm sleeping. They usually look for alternatives, but when they try it out and use it and start to get some improvement in their sense of tiredness, in the way that they're thinking and their memory and their cognition, then that drives them to use the device. Yeah, so in general, quality of life will improve in people with even mild, moderate, or even severe sleep apnea who are given CPAP therapy. And then it has a whole range of other cardiovascular benefits as well, including reductions in blood pressure. So hopefully that's given you a sort of a bit of an overview, and I'm happy to take some questions.